many of us are member volunteers. But there's some literature on the back table about CCV, particularly the website. There's also some literature on the back table from a former program we had about getting the most out of your doctor visit that's printed nationally. But at any rate, and some goodies Mark keeps telling us. But anyway, the big message is that CCV is here. We would love you to, if you're not a member or volunteer, to look into it a little bit. It is obviously a pleasure and an honor to introduce Dr. Barbara Bergin, mainly because there are not many times you get to introduce a Renaissance woman. And what I mean by that is she spent 13 years in Lubbock, Texas, part of 4 years as an undergraduate, 4 years as a medical student, and then 5 years as an orthopedic resident. She is an uncommon woman because when she finished school, I didn't talk to her about it. There were not a lot of women in her class, I suspect, just as there were in mine, and even fewer in her orthopedic residency program. She knows her way, however, also around a cow saddle and a cow horse, and is quite adept at that. She's the author of several novels. She was the co-founder of Texas Orthopedics and practiced there for 37 years until recently retiring. Almost to our most advantage is she's very interested in preventive education, teaching us how to do things better as well as what to do when it's actually wrong, and we look forward to hearing more about that. When she really gets bored, she takes up her guitar and plays and is a songwriter too. That's great. There's a website that she may make reference to for some of her posts. She is a parent and is married to Dr. Paul Mater. It is with a real pleasure, Barbara. What the format here was Barbara will talk till she gets hoarse, but hopefully stop at about 45 minutes, and then we have time for questions because senior citizens get old and creaky in their bones. Thank you for coming.
Well, I was born there for a few years. Yeah, I mean, a lot of people are from New York because it was such a huge place compared to the rest of the country. But we got to Texas pretty fast. So, okay, you can ask questions while I'm talking, and you may want to ask questions. This talk is very long, has the potential to be very long. And so I'm going to fly through these slides because I want you to learn as much about how to take care of yourself. And as time goes by, as I continue to talk, you're going to see the pattern of the things that I recommend that you do and what I do. So as I got older, I started realizing, hey, I'm experiencing all the things my patients have. And what can I do? How am I treating myself? And I started actually using those on some of it on my patients. Next slide. So I retired just a little over a year ago, and I completely retired. I mean, I still run my blog, drbarbarabergin.com, and most all of this stuff is on that blog. And it's basically a medical self-help blog. And you can literally, you know, if you have hand pain, you can go on there and say hand pain, probably figure out what I might want you to do. Next, I do a little tiny bit of teaching at the medical school. Okay, and just start going through this. I think that, all right, let's talk about what I've done to treat my pain, treating some conditions I'll probably get, treating patients based on my own experiences, what I'm doing to prevent some things, and staying out of the operating room and out of the doctor's office. It is not about detailed definitions, the pathophysiology. We're not going to talk about studies supporting my treatments. We're not going to talk about evidence-based practices on how I treat myself. And we're not going to talk about a bunch of surgeries you can have or my gynecological or gastrointestinal diseases. And we're not going to talk about vitamin C, DV oil, or collagen. So in general, as time went by, my patients started to say, well, you're just Dr. No. And I don't know if y'all remember him, but anyway, I found that it's easier to tell patients what not to do than what to do. Because if I say, well, take anti-inflammatory, take some Advil. Oh, well, doc, that bothers my stomach. I'm on a blood thinner. Okay, well, don't do that. So it's easier to say, don't do these things. And that's certainly what I've done for myself. This is me, Dr. No. Next slide. All right, we're just going to start from the top and work our way down. We may not get through all of this. So if we don't, I think there's 200 something slides. When you're, like I said, if we don't get through it, then you can get access. We're gonna post it, or we can do part 2. Some groups have me back for part 2. Some groups say don't ever come back here again. So we're starting with the neck, and next slide. So what I do on here, and you're going to see the pattern. So if you were to look this up in the future, which I recommend that you take this and you get the slides and you use it as a resource, is we're going to kind of go through the most common things that I see. And then the ones that are in blue are the conditions I have. So I can't remember ever straining my neck or having a muscle ache in my neck, but I sure have degenerative disc disease, and I've had a couple of pinched nerves, which was very disconcerting. Next, and when I talk about pinched nerves, it's when you have a neck problem that causes numbness to radiate down your arm, even weakness or pain. A painful, numbness is one thing, but painful numbness, that's terrible. So, you can get a pinched nerve from either a herniated disc, but as we get older, we're not as likely to have herniated discs as we are to get degenerative disc disease, which results in spurs that push out. And let me find my pointer here. Is this also a pointer? Yeah. That push out and crimp your nerve. Okay, so next. Now, what we're going to do is, first of all, reading glasses. Okay, I just noticed I did the thing that I don't want you to do. I came over here to read this, and because I've got transition lenses on, in order to read this tiny writing, I had to raise my head up. This is so bad for our necks at this time of our life. You should never, you should do everything you can to keep your head straight. Oh, next, I want to use this to put. So next, reading glasses, particularly at the computer, because that's where you're going to be sitting and you're going to have a tendency to go like this in order to see the writing. Next, larger computer screens. That's very important. Just get the biggest screen. My husband, I put his on a television on the wall. It's humongous. He just has to open his eyes. So larger computer screens. Next, raise them up so that you're not, raise them, lower them so that your head is straight like this and not going like that. And certainly also not too much like this, just like that. Next. Everybody who has neck problems should get this book, Treat Your Own Neck by Robin McKenzie. Read it. My patients will buy the book and then they won't read it. They'll bring it in to me. It's brand new. I got the book, and you got to read it, and then you got to do the stuff. Next, right, to raise it up and look. Yeah, that's the book. Next, it's basically a form of exercise. McKenzie was a physical therapist from Australia. He's dead now, but he did this exercise called the McKenzie exercise, and basically it kind of straightens out your neck and gives room for your spinal cord. And I literally have done that exercise while I had a pinched nerve and had that numbness go away. And so it's really a good exercise. And I recommend everybody, and if you know anybody with neck problems, get them a copy. It's like $6. Next, activity. Okay. Avoid extended extension. The 2 times that I got a pinched nerve in my neck, I can relate back to having stood for a long period of time with my neck up like this and looking at something for a long period of time. And so this is just the worst position for you to be in if you have any degenerative disease, and 99.9% of you all, me, do. So no, take a quick look or step back. Well, earlier there was a row here. And so I knew that I'd be looking at my slides like this. And at the end of it, I'd be like, oh, so no, I know, unless you've got somebody that can take you on a pallet, you know. Anti-inflammatories, I love mental dose packs. Okay. Tom, I know you probably just are like, what? This orthopedic surgeon, she doesn't know. But I always have one on hand. And so, but I try to stay away from taking pills as much as possible. And there's a whole field of medicine that tries to get older people off medication because every medication has side effects. And I keep working on trying to get my 90-year-old parents off of their medications. I mean, I don't want to kill them or anything, but they're taking a lot of stuff that they've been on for a long time, probably don't need to take. Next. Shoulders. Okay. Next slide. Shoulder pain. Bunches of different. Okay. And then remember, in the blue is stuff I've had. You're like, man, she's a mess. And that's true. That's why I have all this experience to share with you. It's great. My patients love it when I'd have come in with a broken arm, or I'd have, I do this horseback riding stuff. I'm always busting something up. And I'll come in with a brace on or a cast on. My patient's like, oh, that's so great. They don't feel sorry. They're like, that's so great. You can understand. And I'm like, I do not need to hurt myself to understand what you're going through. But myofasciitis, it's that pain right here that mostly women have. And if you just reach back there and push there, you feel this pain. Rotator cuff disease, 60% of us are going to get that impingement, which is part of rotator cuff disease. Bursitis, also part of rotator cuff kind of disease. Cervical radiculopathy, but that's the neck. So when you have sort of radiating shoulder pain, it's not the same thing. Osteoarthritis, just basically getting arthritis in your shoulder, not as common as, say, arthritis in the weight-bearing joints. So myofasciitis, there it is, this pain right here. Sometimes it goes down between the shoulder blades. I have it all the time since I was probably 20, and I just have to live with it. Massage therapy, just rub it, stretch it, just do stretches. Tennis ball massage, back. There's a gadget called the back knobber you can use, and ignore it because it's not pathologic. It's not harming you. There's a tennis ball. Have y'all done tennis ball massage? You just get an old long sock, put a tennis ball over the back, and then you can lean up against a wall. Next. Change the way. Okay, now we're on to impingement syndrome. How many people have had rotator cuff problems? Yeah, it's pretty common. And so the first thing to do, and you're going to see that this is a common way that I address, change the way you do things. Stop doing things that hurt. Rearrange your household. Change your elective workouts. Stop some things completely, and we're going to go more detail. All right, next slide. Okay, here's just a whole bunch of things that we should all be doing, and especially if we've got any problems with our hands, upper extremities, elbow. Use electric toothbrushes. It's better for you anyway. Use step stools, but not dangerous ones. I mean, do not be going into closets and reaching up and looking up there and reaching up and getting something. Use step stools or use graspers. Get rid of heavy purses, lighten your load. Don't try to carry bunches of stuff in. Don't put your purse in the passenger seat like that. If that hurts you to do that, then stop doing it. I have no pain, even though I've had this in my shoulder, I have no pain. I, I take my purse and I kind of go in the back seat like that. Lifting closer to your body rather than reaching for things. Get up closer to things that you want to lift. Cut your hair short. Yeah, there you don't have to worry about it anymore. But people are when you have longer hair, you're having to do this. There's a floor-based hair dryer. It just looks just like a regular hair dryer, only thing it's weighted, and you just bend over, or you can go out like I did when I was in high school. I had long hair and I went outside to the air conditioner, and when the air conditioner was on, it would blow dry my hair. Put your bra on in front, or get a front fastening bra. Now, when I have an all ladies group, we talk about this more in detail, but who invented the back snapping bra in the first place? It's a ridiculous thing. And just get a front snapping bra. Yeah, well, okay, not pay somebody to put your bra on. That kind of, but I mean, you could do that. But but pay somebody to do the jobs around your house that are dangerous and overhead. Rearrange your household. Move pictures that why do we always have to put the pictures in the milk cartons up here just because that's the way the fridge came? Convert lower cabinets to those pull-out drawers. Get rid of heavy pots and pans. I love my all-clad pots and pans, but man, in a few years I'm gonna have to get rid of those things because they're ridiculously heavy. Move heavy things to lower shelves. Declutter. Just go through your house now. Don't make the kids do it later. Go through your house now and declutter. Get rid of stuff so you can find things more easily. Change your elective workout. Next slide. So, this lady, she's got a whole bunch of pictures on the internet. She's crazy. But look, we don't need to be doing heavy weightlifting. So if you're doing heavy weightlifting, stop. Go to light weights. The objective is stay healthy, maintain your muscle mass, but not hurt yourself. When you tear your rotator cuff, you're in a world of hurt. It takes a year to get over that. Stop some things completely. Next. This kind of stuff. There's a lot. I hope none of you guys are like this out there playing basketball with a 20-year-old. Okay, push-ups, pull-ups, dips, and heavy weightlifting. Just stop those things right now. And I should, now that I'm retired, I'm more free to say that. Before that, I'd be like, hey, I'm cutting out some business here, and I tell you not to do push-ups because this is what people are hurting. This is great for orthopedic surgeons. Like this exercise where you put your hands behind you and you dip down and push yourself back up. That's a squat is when you're just your arms are free and you're just squat or you've got weight, but a dip is you put your arms behind you and you lower yourself with your arms. Go do something which produces happy hormones. Okay, this is an important concept. I'm a person that has a high pain threshold. Don't ever go to your doctor and say, doctor, I have a high pain threshold. Because we all sit around at our meetings and say, patients that say they have a high pain threshold really have a low pain threshold because you're getting ready to say, but this really hurts and I need a pain bill. So, but we all have the ability to reduce our pain naturally. The problem is many of us over so many years, decades, have reduced our ability to tolerate that by taking medications, seeking the attentions of doctors for pain pills and stuff like that. But we have the ability to, first of all, splint ourselves. Something hurts, you can carry it around a little bit. You can limp a little bit. You can rest. If something, if you're a caveman, that's all you can do. I mean, if something or someone's trying to kill you, then you may have to die. But if you can limp, if you can carry your arm with you, that's what you're going to do. We also have this amazing ability to forget. And so when you're sitting there going, oh, I'm afraid of what the pain might be, that's just creating anxiety. You're going to forget that pain. Next. Okay, you can find a million of these throughout the internet, these little graphics, but you should copy one and put it on your refrigerator, because these are the happy hormones, and these are the things that help you fight pain and help you find the negative feelings of anxiety that you have. So you go, okay, those are the 4, and these are things. You complete a task, you practice self-care, you eat some food. That one works really good. And so I literally read these every once in a while and go, okay, I've got a little aching in my knee, I'm going to have some dark chocolate, but so get one of these or copy this one and put it on your refrigerator. Yes, and when you're having pain, you go do one of these things. Elbows. Okay, next. Okay, I've had a lot. These are the main 4 things. I mean, there's other things terrible things that can happen in your elbow, but these are the main things that a lot of us suffer from. Tennis elbow, electron bursitis, cubital tunnel. I've had all those, and I haven't. So tennis elbow next. Nothing works. Orthopedic surgeons are so frustrated with tennis elbow. And as you probably know, tennis elbow isn't usually caused by tennis. As soon as they invented these big rackets and put some science into the stringing of tennis rackets, tennis elbow. Oh, pickleball is just like the orthopedic surgeon's dream. We love that. We love that sport. But no, it's not as bad because the racket is different. And you like handball and racquetball. Say it's a smaller racket, not as much force. But people aren't hurting themselves anymore playing tennis. It's very rare to see a tennis. Most of it is the stuff we do around the house: cleaning, lifting, grabbing things. Rest, rest, and more rest. And you see the depressed lady on that picture. Rest. Okay, we try because you come see us. And but I had tennis elbow in my right elbow for 1.5 years, and when I got over it because I overused my left, I got it over here for 6 months. And so if an orthopedic surgeon is going to have it for 1.5 years, you are too. It is a very complicated condition because of the way we use our hands. Yes, we use braces and then we rest. Then anti-inflammatories, yes. Injections, they don't work. More rest, surgery. And we sit around and we say, the reason surgery works is because then people finally believe they got to rest because they've had an operation, right? Yes. Oh, yeah. I mean, anti-inflammatories. Oh, yeah. Oh, okay. So danger in anti-inflammatories, yes. And the biggest danger is that a lot of us are taking an anti-inflammatory, an over-the-counter, that's Advil and Aleve, aspirin. We don't do that as much. And then on top of that, we're taking Tylenol. And on top of that, we might have a painkiller that has some Tylenol in it. So and then you might have a couple of drinks. And so we are just killing our livers. And, non-alcoholic liver disease is a big problem nowadays. And so we have to be careful of anti-inflammatories.
Hello. A quick word of wisdom about Advil to be on the safe side, particularly as long as you stay under 1,200 milligrams a day, which is 6 tablets. If you say below that, you're not going to hurt much.
Yeah.
Much.
But then and here's where I'm always, where I talk about being Dr. No. it's easier for me to tell my patients not to take them than to say stay under 1,200 milligrams, because they may be taking maybe Limonene, other medicines they're on, or that they're, drinking, having a case of beer every day. And so it's easier for me to say, don't use them. And this talk is about what I do. And so I rarely ever take an anti-inflammatory. And because I do all these other things, I find I don't need to so much. But yes, they're great medications. And for many people, they're extremely important. Okay, even down to the littlest thing. Again, electric toothbrush. When you use a regular toothbrush, you're holding it like that, going like that. Electric toothbrush, you can just hold it like this. And people with tennis elbow will get, and you may be saying, I don't have tennis elbow. That's this pain on the outside of your elbow. And cups with handles rather than holding these big Yeti cups, that's a real problem. Smaller cups, styrofoam cups, everything smaller, not grabbing big things. No books, use Kindles. People with tennis elbow, they go nuts with this condition. And so you have to, everything that hurts, which is everything. I'd be standing here with this thing and I couldn't use it. I'd have to be like, oh. Question?
If you use a Kindle instead of reading books, doesn't that put your neck down?
Well, you have to position it somehow. And you'll see, I mean, we're going to talk about other things with regard to the Kindle. Yes. I mean, you have to kind of move things around and position things so that you can read.
Okay.
Books on tape, I know I like to read books. I don't like books on tape. But there's a lot of conditions that are the result of us using our cell phones and our Kindles and our books and reading in bed. All right, weight machine with no grabby parts. So people are like, I've got to go to the gym and now I can't hold weights. So there's machines where you can just go like this and you can just go like that, and you don't have to be grabbing. Cut your hair. Want everybody to get a short haircut, see? Box cutters and scissors everywhere. Do not tackle plastic bags and try to wrestle with these terrible plastic bags and say, tear here, and you're like, where? Buy a new car. I mean, I had some patients that could not turn their car on, and so they have to get these push button cars. All right, bracing, yes, because it'll force you to rest. Next. Let somebody else do it. Point, but don't point too aggressively because it'll kill you. And then, go see a shrink, because it is one of these conditions where when you can't do things, people just really get sad. And then you have to go do your happy hormone stuff. Okay, electron bursitis. A bunch of people are going to have that. It's when you get swelling back here. And it's, somehow I skipped to is there one? Well, no, that's okay. Padding, wrapping it, pillows. I'm a big proponent of using pillows. Use pillows all over. Have 10 pillows in your bed. One's under your knee. One's over padding the side of your hip. One's got your neck going this way, and the other one's got your shoulder going this way. And then you got a couple at the bottom for your heels. Pillows everywhere. They're really good things to use. When I had electron bursitis from going to horse shows in my car with my arm on the console and just leaning on it for hours at a time. And so I have a big pillow in my truck. Yeah. I have an adjustable bed, and I think they're great, but I found that I don't use it as much as I thought I was going to. I thought there would be a lot of good uses for it, but I ended up using pillows. But yes, if it works for you, but the adjustable bed still doesn't pad places that are rubbing, So anti-inflammatories, steroid packs, injections, they suck the fluid out, put a little steroid in there, surgery, but that's last. I mean, that's only for chronic cases. But olecranon bursitis is from setting your elbow and pushing off. A lot of people use their elbows to push off. A lot of people who have pulmonary problems use their elbows to raise their chests up so it helps them pull oxygen in. And so those people will get huge bursas, and they get infected sometimes. Next. Oh, yeah. All right. Before you can make it better, figure out what's causing the problem. So you have to figure out, I'm resting my elbow. I'm doing this. Try to figure out what reproduces the pain and make those changes. So again, with the elbow, leaning on consoles, leaning on the arms of chairs, using your elbows, reading in bed. Yeah, back to Dr. No. Don't do it. Ulnar neuritis, that's when you get numbness in your pinky and your fourth finger. This is a very common condition, and it's become more and more common since we started using cell phones, because we're always like this. But that puts tension on that nerve, and then we're setting it on our arms, the arms of our chairs. But it's the fact that we're staying with our arms bent so much. So if you're sitting there and you're using your cell phone or you're reading a book and your fingers are getting numb, it's more likely due to ulnar neuritis than to carpal tunnel. And the carpal tunnel are these three fingers, and ulnar nerve is your pinky, the funny bone nerve. And so that nerve is right here, right under the skin. And if you, with your elbows bent all the time, if you're getting numbness, it's because of that bent elbow. And you've got to spend more time with your arms. I mean, it's a really dumb thing, but I've had it and I made it go away.
What about your hands going to sleep at night?
Yeah, that's carpal tunnel syndrome. So most people feel like it's their whole hand that goes to sleep, because it's these three fingers and half of this finger. So you wake up and you think, it's back. Or, it can be due to the neck, but usually it's not. It's usually carpal tunnel. I had carpal tunnel releases, and I still get.
Doctor?
Probably about 5 years ago, I started having it back again.
I was diagnosed with it, and this hand and my thumb is still kind of numb. And I went to Texas Orthopedics, and they did the electrical test and everything. And then the doctor was saying, well, how about the surgery? And my son's girlfriend's a masseuse, and she says, no, get massage. There's massage that can help. So I got some massages, and it did release the burning pain when I twist my hand. My thumb is still a little numb, but the doctor said the numbness takes longer to go away.
It can go away on its own. I don't know what to think about massage for it. And for everybody, every person that says massage help, there's a whole bunch of people that says it doesn't. The surgery is, it is the most commonly performed operation, and it's the most successful operation that we do. And I've had that surgery, you've had the surgery, but 20 years later, if we're doing a bunch of this stuff and we're sleeping at night then it can come back. But the problem with living with a numb hand is that as we get old, eventually we reach a state where we can no longer dress ourselves. So the nerve that makes your thumb numb is also the nerve that innervates a muscle that comes across your hand and allows you to go like that. And that begins to get weak, and that's what causes grip strength weakening. And I don't know if any of y'all had a surgery recently where they gave you the grip strength gadget and asked you, yeah. Okay, so for some reason, grip strength is associated with good health. And my 90-year-old dad needed to have an aortic valve replaced. And we're like, oh my gosh, Dad, you're old, for a big operation. Well, they did a grip strength on him, which is great. He golfs there, 2-3 times a week. And He lifts some light weights and does some exercise. And they did a grip strength and they did an in and out of chair 5 times. They asked him a couple of questions and he passed and he had the surgery and came through with flying colors. And, was back to golfing in about 5 days. So what were the factors? What are the factors that lead to them deciding that grip strength is important? That just means how active are you? How much are you participating in normal daily activities? And as your hand gets weaker and weaker, then you stop doing a lot of important things like dressing yourself.
For carpal tunnel. And so my orthopedist said, well, I'll give you physical therapy. Usually it doesn't work, but give it a shot. Well, I did it, and it took me about 2 months of physical therapy, doing the exercises at home, and it's worked very well.
Yeah, and
I'm very lucky.
Again, it may work, and let's so we can get through as many things, because I did this for 36 years, and really 40 something years if you can include. And so I'm telling patients, hey, I'd love to avoid surgery my own self, but I had it on both hands. And we just see a lot of patients who never have it done. And, my dad has had numbness in his hand for years and years, and I can see it's all wasting. His hand's very wasted. Yet he's a big man. And, but you reach a point where you don't want to have surgery anymore. You get into your 80s, you don't want to have an operation. And so you will bypass the time. You'll reach a point where the nerve is permanently ruined. Okay. And so I just think carpal tunnel is such an easy operation to go through, but let's not focus too much on that. But if you're getting numbness in your hand, don't ignore it. If you can't make it go away by trying to sleep with your hand, but we all do this at night. Every single person does this with their hand at night. That's probably what causes it. Eating in bed, next cell phone use. Look at this girl, she's leaning. Okay, back to, now we're on to hands, because that was about the ulnar nerve. So hand, continue. Carpal tunnel syndrome, very common condition.
And de Quervain's osteoarthritis and
Orthopedic surgeons believe that almost all of us get some level of carpal tunnel syndrome, and that may be the reason that we get weak when we get old. Trigger fingers, that's when your finger locks up and you can't straighten it. Osteoarthritis in the hand, de Quervain syndrome, de Quervain's is this little weird nerve pain that, and I only put it there because I got it and had surgery on that and on the carpal tunnel. Next slide. Okay, mindfulness, and this is an important thing. Paying attention to your pain and recognizing pain early and not ignoring it. Resting things that hurt. These are the same principles that we've already discussed for other conditions that we're going to apply to everything else. Activity modifications, things that you're going to stop doing. Next. We're going to stop, I've gone through periods where I've had to stop playing my guitar because the ulnar nerve was so irritated. And then it got well. Grabbing the big cups, using your cell phone all the time. Do more, less typing. Use your voice recognition. Doing weird exercises, of course. If you're doing something that's hurting you, that's elective, and you don't have, it's different if you're, your personal hygiene. But if you're doing an exercise that's hurting you, stop. Rest. Don't be so grabby. We're always grabbing things, holding less, pick up less things. Don't be as repetitive with your grabbing. Splinting. Okay, carpal tunnel often will get better with some bracing if you catch it early. So a brace that keeps you from going like this at night. Shots. All right, so I would never, a lot of people get benefit from getting a shot in their wrist. Has anybody here had a shot in their wrist? Yeah. I would never take them. They hurt like hell. But you might be more tolerant, I won't take a shot in my hand. I usually have a principle of saying when I was practicing, I would not do anything to a patient that I wouldn't have done on myself, but I would give people a shot in their heel or in their wrist if they wanted one. Because they can work, but I mean, I was the world's best shot giver, so I could give a pretty painless shot. Again, don't be so grabby. Surgery works pretty well on most hand problems. A lot of it can be done under local anesthetic. Do not be so afraid of surgeries on the hand. Next. There's a picture of a shot. Oh, all right, next. Surgery, okay, next slide, back. All right. Back pain, lumbosacral spine strain, degenerative disc disease, sacroiliac pain, sciatica. I've had all those except the strain. I've never strained my back, but I've had some back pain. I mean, they say 99% of us are going to have back pain at some point. Again, activity modifications, low impact exercise, physical therapy, home exercises. Okay, let's skip ahead so that we can get on with this. Next. Squaring up your movements. Next slide. Okay. When you're getting in and out of a chair, if you're sitting there, like this, I don't want you to come from here and jump up. Okay. I want you first to sit up. I want you to get out of the chair straight. I don't want you twisting. Why I have that picture is there's this man getting out of the car. We tend to get out of the car and we got to scoop this knee under the steering wheel, and then we got to do this. Swing your legs around and stand up straight, like your mom told you. All right, next. Treat Your Own Book, but Back by Robin McKenzie. Next. There's a picture of it. Next. Stretch your back before getting out of bed. I have a really high-tech slide on this one. Next. Okay. So I couldn't find it, so I drew it myself. What do y'all think? That's pretty good. Anyway, a patient told me this, and I was like, that's ridiculous. So I went home and I tried it. When I get up in the morning, I have some aching in my back. You've been in one position all night, you straighten out, oh, there's a little ache. I just lie face up, push my heels down into the bed. And there is this sudden relief of pain, and boom, then I can swing my legs around. So I'm not going to get out of bed like this. And I'm going to swing my legs around, and then I'm going to stand up. And it makes a huge difference. I want y'all to start doing this if you can. Now, if it hurts you, don't do it. All right. These are, anti-inflammatory steroids injections. These are treatments. Yes, you can have them. Ignore if you want to, and if your doctor wants to give them to you. Ignore it if you can. I mean, if you're next slide, next slide. I think this. I have to know. Next slide. On steroids. Okay. Tom, I like steroids. I mean, I don't take them like a drug, but if I get something that's really, really bad, like pinched nerve, I'm going to take a steroid pack. Have steroids will travel is what. All right. Is it hurting you now? I used to ask my patients that all the time. They'd be like, I hurt all the time. Whatever is killing me, my pinky toe. I'm like, is it hurting you now? Well, no. Well, then do that more often. All right. If you're not having pain and you can find positions of painlessness, seek those positions. And most of us are not in complete agony every minute of the day. Seek that position more often and work on getting some happy hormones. Next. All right. This is an important thing for your back and for your knees. Your couch begins to sag and it's low and you're getting lower and it's, you're kind of, and you don't want to get rid of it. Then here's the option. And I did this with a couch. Now you have to get a decorator pillow. Next slide. So you go get a dog pillow and you find the one that's almost the size of your couch pillow, and you buy one that matches the color. I kind of found one that was the kind of the color of that previous house. And you stick it under the top cushion. You can't imagine how much better your knees and your back and everything is going to feel if you elevate. Now, a patient of mine said, Doc, why don't you just get a new couch or reupholster your couch? And I was like, well, I just didn't think about that. I'd rather use a dog pillow. It's $45 to beef up all of them. Sit up straight before getting out of a chair. So remember, we're going to turn around. So we're straight ahead where we're going to go. We're not going to twist and go that direction. We're going to go here. We're going to sit up straight first. Next slide. So you're not going to go from there to standing, because then you're going to be like, oh. Next slide. You're going to sit up straight first. You're going to get to the end of that chair, and then you're going to push yourself up. Next. Is it hurting you now? You're going to ask yourself that question more often. Next. And ignore it. I put the guitar in there because sometimes I just, if I'm having an ache or a pain and something while I'm playing the guitar, then I just don't play it right then and there. All right, go ride my horse. That makes me happy. And I'll just go get on that horse, look at it, and isn't he cute? You get with your grandkids, go play with a baby, do things that make you happy. Next. Seek positions of.
Can you show us again, Barbara, can you show us again how to sit
All right.
and stand up straight? Because I find myself having to lean forward and push with my arms. And so
Well, it's okay to use your arms to help push yourself out of bed. Now, what they ask when you go to have a great operation like an aortic valve replacement, they're going to ask you to get in and out of a chair 5 times without using your hands. And so I think that we got to, so you can have that operation instead of die, then I'm like, Dad, if you can't get out of that chair 5 times, you're going to die. Anyway, so we got to be able to do that. But even if you have to struggle, just do it. You're sitting around like this. Okay. We're not going to just go like that. We're going to get from here. We're going to sit up straight. Okay. Then we're going to get our foot underneath us. And if I want to go over there, I'm not going to just go there. I'm going to use my hands. You're going to stand up. It just makes a difference sitting up straight first and facing. Yeah. But he was able to do it 5 times without his hands, so he could have that surgery. It's got to be, if you're getting ready to have an operation, you're like 80 something years old. Just make sure. A lot of doctors are doing that test now, the grip strength but if you're demented and you've got great grip strength, they're going to ask you a few questions too, So, all right, next. And if you can't do all those things, you're just going to go see a shrink. All right, hips next. Okay. Oh, we're an hour into it. Okay, let me tell you. Let's skip to go way ahead because you're going to be able to look these things up. But at the end, keep going, keep going, keep going. We're going to go all the way. There's some important concepts here. We're going to have to skip knees. That's me falling off my horse. I think y'all are going to have to, I never get through this whole talk because there's too many important. Okay, we can go. All right, arthritis of the knees, aging process, old injuries, genetic predisposition. We also associate, when you're told by your orthopedic surgeon that you have a degenerative meniscus tear, and anybody over the age of 40 with a meniscus tear, it's part of having arthritis. You're not the same as the 20-year-old football player that just tore his meniscus because somebody hit him from the side and landed on top of him. When you get out of a chair and you have sudden pain in your knee and you see the orthopedic surgeon, they say, oh, you've got a meniscus tear. That means you've got arthritis, okay? Chondromalacia. Oh, that's a disease of the cartilage. That's arthritis. Stress fractures, bone edema, and stress reactions, that's part of having arthritis. It's not the same as a broken bone. people say, oh, I need to have the such and such because I have fracture in my knee. No, it's because that's a stress reaction. Next. All right, again, we're back to, if it hurts, don't do it. Change the way you do it. Yes, you can get physical therapy. You can take anti-inflammatories. You can get shots. I want you to modify your furniture. I wanted you to lift up your couch. I want you to sit in a higher chair. Get that elevated toilet seat. You can either buy an extension or you can get a real one. And but use that. Do not continue to sit on the toilets that are the same height as they were in 1900. Do not tuck your feet underneath when you're sitting. Weight loss. Okay, there's a huge factor with weight loss. It's a struggle. My entire adult life, I've been struggling with that, but there are huge factors that contribute to the wearing out of your knee. And I've had many patients who do lose weight, reduce their, end up not having surgery. And surgery, you can have surgery, of course. And now keep going, keep going, keep going. Injections, these are all the shots. And what would I do? Sure, I'd take a cortisone shot. Yes, I'd take a Synvis shot. I'd probably do a biologic if I felt like spending the money. I might let somebody know. We can't, I can tell my doctor to stick a saline shot in my knee. I don't think y'all can. I mean, I think a doctor can say, hey, yeah, stick, because, they've studied a lot of these things compared to saline. Saline works pretty darn well. But you can't go to your doctor and ask for it because that's not approved for that. Next, furniture modifications. Yes, do the couch thing. You've got to elevate your couch. Next, elevated toilets, grab bars, bathtub conversions, shower transfer chairs, widen drawers. Do all this stuff. Next. Okay, next. Do not sit with your foot tucked underneath you. I said so. It's an interesting thing. And let me tell you, it's, I saw, how did I come up with this idea? Did I just make it up? No, because I saw tons of patients who said, oh my gosh, I can't sit on my foot anymore. It's mainly women. You do not see guys sitting around tucking their knee up underneath them. Women do it all the time. I have a theory that when we're cave women, that, the guy can kind of sit on the gravel, right? But us ladies, we couldn't go sit on the ground. So we put our foot underneath us to have something to sit on, right? So I think it's sort of built into us because I can barely go get in my bed when my leg's not coming up underneath me. So I have to make myself not do it. When you bend your knee, when you hyperflex your knee, that's when you get that degenerative meniscus tear. And so when you bend it up under it and then you sit on top of it, it squishes that meniscus. Stop doing it. I think forever. I don't think we should be doing it. We need to stop. Now, young people are not going to tear the meniscus, but it's going to be if you can tear it when you're older, you're weakening it when you're younger. So next, the weight multipliers, you can look at that. It's, when you get up out of a chair, 6 to 8 times your body weight into your knee. When you get up from a squat, that's why I'm like, no squats. Discontinue doing squats. That was my first blog post, was do not do squats. All right, next. You can have a knee scope next. Now, I'm sure some of y'all have had knee scopes, and they're good operation, but they're for the treatment of this arthritis. It's different than when you're a 20-year-old football player. When you have a scope, when you're 40 plus, you're removing arthritic tissue. You're removing that meniscus. You're removing loose pieces of cartilage. It is not going to last forever. Now, every once in a while, you got a patient that I've had patients that last for 20 years. And I'm like, oh my gosh, that's amazing. But sometimes it only lasts for 6 months. Yeah.
So Barbara, getting up and down off the floor,
Don't.
don't get on the floor.
Right. I can't tell you the last time I sat on the floor.
Well, I can't either because I can't do it and I'm
Right.
afraid of getting up.
Yeah. Don't,
So,
if you have anxiety, if you worry about something, then about the future, then, then don't, because it just gives you anxiety. Don't get on the floor and stop taking baths. You take showers only. I had an 85-year-old woman. They took her last bath and she couldn't get out. She had to call EMS. 5 EMS guys showed up at her door. They just all sat down and had a nice little interview with her while she was in the bathtub. And then they got her naked body out of that tub. She said, I will never get to take a bath again. And I'm like, stop taking baths. That I can't even imagine. Yeah, I don't get on the floor. One time my glasses fell and how does that happen? It slid under the bed. I mean, I was contorted getting down on that floor because too many people get up from a squatted position, and that's when you tear that meniscus. All right, what the next? Why hating on, do y'all want me to talk about why we are hating on total knee replacements? You can read it. Next. Total knee replacement. I mean, okay, it's very fast. Best results, older trim patients, poor results on young overweight patients, but we're so much bigger now than we used to be that we're doing lots of total knee replacements on young patients. Well, they're going to wear out. Then you're going to have a revision. 20 years, it's how long they last otherwise, but when you're younger, they're going to wear out faster. Infection complications are higher in overweight patients. No weight loss. People say, I want to have my knee replaced so I can lose weight. Studies show nobody ever loses any weight after knee replacement. And there's probably a few people that do, but most people don't. Most people are just, weight. Again, I struggle with my own weight. But weight is something that it's a very complicated condition. And it is, to me, it is not a bad habit. It is a metabolic disorder. And, it's very complicated and a very low success rate in terms of permanent weight loss. Yes, there are people who lose weight after a knee replacement, but the majority don't. So you're not going to say, I want a knee replacement so that I can lose weight. You're going to say, I want a knee replacement because I have pain that didn't get better with conservative treatment. All right, so when you're old enough, you're trim enough, and you failed a conservative course of treatment, when you know it's the right time, you've done everything to stay out of the operating room, and you're plenty unhappy and can't get enough endorphins by looking at kitty cats, then you get your knee replaced. Bone bruises, bone edema, stress, these are all part of having arthritis. Next. I'm doing this exercise. Hey, you went through that one. A lot of people say, they're doing aggressive exercise programs. They're squatting, they're running, they're jumping. I'm doing this to be healthy. And I'm like, stop doing those exercise programs because they're getting you to the knee replacement, which is not, it's not a healthy operation. We're zipping your knee open and exposing your entire knee to the environment. Okay, so that's just what I would do. All right, let's just, oh yeah. Yeah, there's no stem cells that are going to cure arthritic knee. Yeah. And, I'm saying I would try all these things rather than have my knee replaced. But now at my age, when I first started giving this talk, I was, 60, but now I'm 69. And so I'm like, man, I don't even know if I'd take a shot. I might just go straight to the total knee replacement. Because, there's now I've reached a good age. When you're 70, that's a good age to have your knee replaced. Next. Oh, you guys can read the rest of these. There's some important stuff at the end that y'all will find interesting. And so I would suggest that you check this out. Any other questions? Like I stand or anybody stands?
You stand on one foot with the other one bent.
You like that?
No.
Like that? Like that?
Uh,
I'm moving around most of the time.
Turn over, and I thought, would that put a pressure on your knee or where?
No, I don't think so. I mean, any standing, people say, oh, I'm having to have my knee replaced because I stood in a factory for my entire career. No, that's what humans do. We're hunter-gatherers. We stand up all the time. And but one of my towards the end is definitely doing single leg standing. You should all be doing that unless you've got really bad arthritis. Yes.
Okay, they say that swimming is good, but getting in and out of a swimming pool is too hard. So what about that?
Well, you have to go live in a place like Sun City, which is where I live now, where the swimming pools have ramps down into them. And so, yeah, you can't climb out of those ladder things anymore. That would be very dangerous to do. So you could just do a cannonball, Hey, everybody, move out of the way. But getting out, getting in, you can just drop in, but getting out, bad.
I have a question that is about calcium pyrophosphate deposits in your knees.
Yeah. I mean, some people have that form of like a pseudo gout. It's just a form of arthritis. And when you have your knee replaced, that all gets cut out and you don't grow it anymore. But you don't have to have them removed. Like you don't have to have a knee scope to have them removed. Yeah.
May I ask you about a treatment modality with acute chronic degenerative joint disease in the lumbar region? When steroids don't work, physical therapies doesn't work. What do you think about spinal cord stimulators?
Yeah, I mean, they work on a lot of people. They don't work on some. Yeah, I think I know a lot of people who have them, and I've had a lot of patients. I didn't put those in because I had partners that did that. And a lot of people have success with that. You reach a point with back pain, with anything where, and some people, it can't have surgery on. I mean, their back, it's not a surgical condition. And so you're kind of stuck. But that's where I'm like, you got to get your endorphins. You've got to find the positions where you don't have pain and get to those positions more often. I know that sounds awfully simplistic, but I've seen a lot of success with the spinal cord stimulators.
How do you trade off doing exercises for cardiovascular health versus like walking, running, versus the wear and tear on your joints?
Yeah. So, a lot of the cardiologists will say, well, you got to get your heart rate up to 80% of maximum, and we can't do that. You'll end up hurting yourself. And so I think there's plenty of studies out there that show that just simply going out and taking a little walk, and then there are some people who can't go out and take a walk. Now, if you can't take a walk because you've got such terrible arthritis in your knee and you've undergone treatment for that and it didn't work, then you need to have your knee replaced. We need to do that before we're too old. And so, so you need, whatever the cause is of you not being able to take a simple walk, because again, that's what humans do. We're walkers. If you're in a caveman group, a group of cave people, and you can't walk and keep up with them, maybe you get left behind, Now that doesn't happen in this world, but walking is the essential thing that we do. And so then you swim. And my husband can't walk for exercise. He's all messed up. And he's messed up beyond all repair. He had total hip replacements and somebody messed up so bad. None of my partners, somebody messed up so bad that it's not reversible. And you've seen him walk around the hospital plenty, and he can't walk for exercise. I mean, he still walks around the hospital, but he swims. The swimming, water aerobics, riding a stationary bike, that kind of thing.
I can't tell you how phenomenally practical, wonderful you've been. It
Oh, well,
really is. Really, really, thank you, thank you, thank you. Because, you know, and
Thank you.
this was recorded, so you can go back to the CCV website. Even if you're not a member, you can go back to CCV website and replay parts of this because she spoke so slow that most of us had no problem, I'm sure. But the point, but I can't emphasize how pragmatic and from a physician's point of view, I thought it was just absolutely wonderful. And one who's had my share of surgeries too.
Yep.
Thank you, thank you, thank you. She will
You're
be here from a
welcome.
few informal questions, but as of this moment, I'll let you stand up.
And really.
The
get-
correct way, of course. Now let's watch it. All right, everybody stand up together.
Right. Very good, very good.